Excellent. Okay, excellent. Okay, so today we're going to talk about refractory vasoplegia. Thank you, Dr. Konecki. I have no financial disclosures to make. Very quickly, our objectives, we're going to review some definitions and circumstances surrounding vasoplegia, some common pathophysiologic mechanisms, medications that we'll see in the intensive care unit and some evidence behind them, and then look at alternative options and kind of where the future's headed. So refractory vasoplegia, profound, uncontrollable vasodilation due to low SVR with either a normal or high cardiac index. And that's what really separates this from cardiogenic shock, though it can be seen in cardiac surgery patients. But cardiogenic shock is a state of low cardiac output. So most commonly occurs as part of septic shock, but can also occur, like I said, up to 25% of post-cardiac surgery patients. However, given the distinct realm of cardiac surgery, we're not going to talk much about it, really just what vasoplegia is. And it's resistant to catecholamine therapy. And when you have shock resistant to vasopressor therapy, it's an ominous sign and carries a high rate of mortality. Can be found in all advanced shock states. And there's a complex genesis involving various mechanisms, which we'll get into kind of briefly, but really vascular smooth muscle desensitization, alteration of secondary messenger pathways like nitric oxide, adrenocorticoid insufficiency, and increased nitric oxide production. I included this. We're not going to get into a ton of kind of patho because it can be so complex and there's so many different mechanisms, but really what I want to talk about here is in healthy humans, contraction of vascular smooth muscle occurs as a response to rising levels of intracellular calcium. And these increased levels of calcium cause a cascade of events, starting with myosin phosphorylation, leading to myosin actin filament cross-linking, and then vasoconstriction. The influx of cytoplasmic calcium is generated by agonism of G protein-coupled receptors, which we'll get into a little later, via catecholamines like alpha-1 adrenergic receptors, arginine vasopressin, and angiotensin 2. Bypass, and this is in reference to cardiac surgery patients, significantly increases the inflammatory cascade response, and cytokines are released due to hemolysis. So this is kind of the background of what happens in vasoplegia, and we'll get into a little bit of what happens individually at the cellular level.
Tanner, so if we do release this, we are assuming you and I know what vasoplegia is, that anybody who would watch this knows this. And are you going to go in like the first line treatments of norepinephrine and Valium?
Yes, absolutely. So we'll talk about the different, how those pressors actually work and what they're indicated for, the evidence behind them, and when we should use what. And this is going to be specifically vasoplegia, so not necessarily cardiogenic shock or the need for inotropy, but we'll go into each individual pressor and the evidence behind it.
Yeah, and then we've already talked about it, and we know like the SWAN numbers, SVR, how to identify vasoplegia. So we may assume that whoever is watching this kind of knows that already.
We are assuming it, and actually this slide kind of goes into the spectrum of it, and the degree of vasoplegia is determined by the dosage or amount of vasopressor. So the worse vasoplegia, all that means is you need higher amounts of vasopressor. The higher amount of vasopressor you need, the worse the vasoplegia is. They also recommend looking at the diastolic BP. So even if you didn't understand SWAN numbers, even if you weren't great with some of the hemodynamic aspects of it, you can know somebody who's on a lot of vasopressor is in significant vasoplegic shock. And so invariably the need for that high dose pressor in the setting of normal cardiac function is vasoplegic shock at the end of the day. Three main drivers of vasoplegia. There, my son Connor likes to drive. We have central, cellular, and intracellular interactions that can lead to this vasoplegic syndrome. So central inflammatory triggers, we've all heard of IL-6, interleukin-6, and tissue necrosis factor activate that neuroimmune system. So when this is activated, that inflammatory cascade leads to the production of endogenous norepinephrine, epinephrine, cortisol, vasopressin, and then indirectly angiotensin 2. And that's what we're going to give exogenously to supplement that system when it begins to fail. And overreaction to the system is those alpha-2 agonist and beta blockade that you see as treatment. So central therapy, you see this interleukin-6 is released from the brain and the pituitary, can be battled with clonidine or dexmedetomidine, or beta blockers is what we commonly see when we're trying to reduce that effect in heart failure patients. But at the very bottom right here, you see that sympathetic stimulation releases that norepinephrine, epinephrine, and cortisol, which leads to increased vascular tone and vasoconstriction. The cellular level, the G protein coupled receptors, the GPRCs, involved in smooth muscle contraction, adrenergic receptors, like we just talked about, vasopressin and angiotensin 1. During shock states, these receptors become desensitized and begin to fail. And that's why we give more and more, because they're desensitized and we need to provide more stimulation to try to overcome that desensitization. And this is the major cause of vascular hyporesponsiveness, and something that we can really interact with. And you'll see here, at the cellular level, we can give that epinephrine, norepinephrine, dopamine, phenylephrine to try to hit those alpha receptors, vasopressin for the V1 receptors, and angiotensin 2 to hit the angiotensin receptors. And so because they begin to desensitize and begin to fail, we need to give extra peripherally to overcome that. So the intracellular pathways, basically our secondary messenger pathways. Nitric oxide is the big one. So nitric oxide, a potent vasodilator, production can be increased 1,000-fold during shock states. And that cyclic GMP, which if everybody remembers from their patho class, contributes to vasodilation. It also includes the prostacyclin and cyclooxygenase 2s, COX-2 pathways. And then a big portion that we're trying to overcome in sepsis a lot of times is that corticoid insufficiency, and we give those steroids. Insufficient synthesis of cortisol, tissue resistance to cortisol, and excessive flow inflammatory responses all contribute to that corticoid insufficiency that we can try to overcome with exogenous steroids. So looking at the intracellular, just what we talked about. So these three pathways combine to produce, potent vasodilation and refractory vasoplegia. So this is just a very quick, this is Ratnani, put this very quick thing together on the different molecules engaged in vasoplegic shock. And one that I want to point out, because I think we talk about a lot, but not a lot of people know, is nitric oxide. Initially was called endothelium relaxing factor, formed by nitric oxide synthase. So in the blocking of nitric oxide synthase, which some of these drugs do later, is really key because it reduces that vasodilation. Nitric oxide rapidly diffuses into smooth muscle, leading to vasodilation, platelet activation, and leukocyte adhesion. And so this picture on the bottom just shows that when you get nitric oxide into that endothelium, the endothelium itself stretches and leads to vasodilation. So if we can block nitric oxide or nitric oxide synthase, we prevent that endothelium stretching. So why does this matter? What's important about this? There's a whole bunch of different cellular pathways. The treatment. So our treatment is going to depend on which one of those cellular pathways we're going down, and each pressor acts on a different portion of the pathway. Our adrenergic vasopressors, I think that's what we're most familiar with, especially in the critical care environment. And we have to know that hypotension from vascular hyporeactivity is associated with increased mortality. So people that are hypotensive and needing vasopressor are independently likely to have an increased mortality rate. So these people are sick and are likely to die if we don't intervene. Typically, we give volume first, and we're not super concerned about cardiac failure. Remember, this is in a normal cardiac output state, followed by the catecholamine infusion. They increase main arterial pressure via alpha-1 stimulation. But we have to remember that certain catecholamines can hit other adrenergic receptors except for phenylephrine. So if you give phenylephrine, it's that pure alpha agent, and we'll talk about what that actually does next. But the other catecholamines have additional effects, which is right here in this nice little chart. So alpha-1, what we were talking about, vasoconstriction, and that's what's most important, and that's what we need in vasodilatory or vasoplegic shock. A lot of other things, if you look on the very bottom, you'll see that epinephrine, norepinephrine, they can stimulate beta receptors. So you get the increased heart rate, the increased myocardial contractility, and then, your beta 2 causes vasodilation. So we're not worried about that too much. But just remember that everything outside of phenylephrine can affect these other receptors as well. So what's the best one? They did a Cochrane review back in 2016, looked at all the data out there. There's no one vasopressor that's superior to any other in terms of mortality. Now, the mortality is the ultimate indicator, the ultimate outcome measure for any randomized control trial in critical care. But there is some data that says that others are better, or some are better than others in certain types of shock or certain indications. So at the end of the day, no pressor is going to increase mortality or decrease mortality. There's no difference between the three of them. But there are certain indications, and we have to take into effect when we pick our pressor the additional cardiac, metabolic, and circulatory effects of alpha adrenergics outside of phenylephrine. So if we want to, minimize cardiac disruption, then maybe we pick phenylephrine, et cetera. So we'll get into which one does what here in a second.
The other question that comes up is, when do you move? When is enough fluid enough? And you move to a vasopressor.
So that's the age-old question, and I think that there is significant literature out there that has not come to a great conclusion of what's volume enough. And really, our volume assessment is, not supported by a ton of literature. Do we do IVC dilation? Do we do end diastolic volume? Do we do diastolic blood pressure? Do we do MAP? What indicator do we look at that says that people have enough fluid on board? For this, we'll go with the Surviving Sepsis campaign. If we think it's septic shock, 30 per kilo of fluid, but we all know that sometimes that's enough, sometimes that's way too much. It all depends. And so that's a question that unfortunately I can't answer, and I don't know if critical care as a whole can answer, is when's fluid enough? But I think an axiom that has been proven more times than the Pythagorean theorem is that a 500 cc fluid challenge is not going to be too much for even the worst heart failure patient. And it's reasonable to give people a fluid volume test prior to initiating vasopressor. What do you do in your practice?
Yeah, it's a good question. It depends on where you come in. Ultimately, first of all, you need to be sure you're dealing with vasoplegic shock, and we're assuming we are, right? There's nothing at 1 liter or 2 liters. For most patients, it's not too much. We always think, where is this fluid going to go, right? So if they're already circling the drain and they're already hypoxic, where we don't want it to go is the lung, right?
Mm-hmm.
So if they're on, my approach is if they're on room air and you're pretty sure it's sepsis, everything's fitting, looks like sepsis, 1 liter or 2, 30 per kilo, however you want to define it, isn't going to cause problems. What happens is you give them 10 liters, they end up getting intubated, and then later down the line, you have to take that volume off somehow. So you try to figure it out, maybe get the POCUS out, maybe look their IVC, maybe put an A-line, look for the variation in the A-line, maybe do a leg raise, but it's really a hard question to answer. And give them roughly 30 per kilo, unless they're heart failure or they're like short of breath, and I'm kind of maybe rethinking that. And then that's probably enough. Move on to whatever you're going to choose. The answer is not 10 liters anymore.
I think that's totally worthwhile. And if you really think about it, if it's vasodilation is the problem, just giving them more fluid is not going to fix that problem. We need to clamp them down, but you have to make sure the tank is full. So absolutely, yeah, 1 liter or 2, as and then start your pressors.
You can maybe make the argument they don't need any fluid, right? Because if the vasoplegia is the problem, you give them some volume, blood pressure goes up, and then it leaks its way through and out, like you're going to be low again. So, this is a good question. Not
it's
zero,
a great question.
Not 5, 6, 7, 10 liters, somewhere in the middle, and then grab the right drug that's going to take care of the vasoplegia.
I don't think you'd be wrong to give somebody 1 liter of fluid who's hypotensive.
No, really the patients you don't want to give a lot of fluid, as you know, pulmonary embolism, if you know it's that, and patients in CHF that are like volume overloaded and their heart's overstretched. But it's hard, especially in the flight and transport setting. Most patients don't have a swan. You don't have all this equipment. You don't know their history. You don't have an echo. It's really kind of hard to figure all this out in 20 minutes,
Oh, absolutely. And that's where, this kind of gestalt, looking at the grand picture, as you said, somebody on room air who has clear lung sounds, they're probably doing okay, can handle some fluid. And that, maybe just brings up the point of continuous reassessment,
Yeah.
making sure that you reassess. So the Surviving Sepsis campaign recommends norepinephrine as our first choice vasopressor. And they recommend adding vaso or epinephrine if needed to raise MAP to target. However, if you see, it's a weak recommendation with a low quality of evidence. They do think that norepinephrine is the first-line drug of choice for vasoplegic shock, and I agree with that, and I think that a lot of the literature supports that. Where you go from there is where things kind of devolve. But I'll present at the very end of this a pathway that's supported by the literature for escalating pressure. So norepinephrine, potent, reliable, and familiar. And there's limited heart rate increase. So I think we're all familiar with norepinephrine. When you start with weight-based dosing, you can start as low as 0.01 mics per kilo per minute. And if you start with non-weight-based dosing, you can, 5, 10 mics per minute. I would recommend using weight-based dosing, though, because I think if you use non-weight-based dosing, it's easy to think about, but it's hard to understand how that's actually affecting, like, to quantify patient to patient, because 5 mics a minute in a 80-pound grandma is different than 5 mics a minute in a larger fit person. So when you use weight-based dosing, it just gives you a little better, understanding of the significance of that dose that they're on. They say that with norepinephrine, there's not the beta-2 stimulation, so lactate's not released as part of that. So you can use the patient serum lactate to guide resuscitation. If they're clearing lactate, you're improving. Where somebody who's on epinephrine, which is releasing lactate as part of that process, you can't really use that serum lactate to say, hey, are we getting better or not? So with norepinephrine, you have that added benefit. And cardiac index is increased without increasing heart rate because of you mobilize splanchnic volume, which increases end diastolic stroke volume. So without putting any extra workload on the heart, you're actually increasing cardiac index and to some degree cardiac output, but you're limiting that extra myocardial oxygen demand. So norepinephrine, first-line drug, what we should be using.
Yeah, your lactate point. This is, for me, it's a good argument, and what most clinicians will start vasopressin after norepinephrine is refractory. And I think that kind of is another, in my mind, you've reason to choose vasopressin over epinephrine.
I would completely agree, and I think epinephrine, and I'll get to it here in a bit, is I think after some time with Bo in the cardiac surgery ICU, I'm starting to think of epinephrine more as an inotrope than a vasopressor. And so absolutely vasopressin next. Here's vasopressin. So it restores vascular tone via non-adrenergic receptors and can decrease cytokine production. We know that cytokines are potent vasodilators. You give it at a straight rate. Higher doses are associated with cardiac digital splanchnic ischemia. So just give it at that straight rate. 0.03 is what's recommended by Surviving Sepsis. A couple trials looked at it. Vanks trial compared norepinephrine to vasopressin post-cardiac surgery and found a lower mortality and rates of AFib with vasopressin over the norepinephrine, but that's kind of a limited trial. Everybody, what they talk about now is the Vanish trial. So Vanks was a really good randomized control trial, but then Vanish came out and they looked at vasopressin versus norepinephrine 2 with or without adding hydrocortisone as a factorial 2x2 study in septic shock, and they demonstrated no improvement in the number of renal failure days, mortality, or any other significant endpoint with the Vanish trial. So when you compare one versus the other, the data is kind of mixed, but I think it's still, as such, it's reasonable to start with norepinephrine. And if you find yourself escalating your norepinephrine, is to add vasopressin pretty early, especially because it's hitting that V1 receptor, the V2 receptor, and you're not just trying to pound more alpha into them.
That's a very good point. I'm asked the question a lot. When do you add vasopressin, and I've also seen it done differently. Some will do it as soon as 0.1 mics per kilo per minute. Some will kind of let that go up to 0.2. But definitely, if you're getting beyond the 0.2, why not try another pathway?
Yeah, hit a different receptor. If you're escalating, just flogging the alpha receptors is not really going to help. So hit that secondary receptor. And the pathway I present later on, I believe they say at 0.2 you should add vasopressin. But I think if you're escalating your norepinephrine, add the vasopressin. And if you
Which
add
is another
vasopressin, hopefully you can come down on the norepi.
exactly, which is another reason to stay, in my view, away from epinephrine, because you're driving the lactate and you're just at higher doses hitting more alpha. So I always choose vasopressin as the second line, and most people clinicians that I know and work with do as well.
It's supported by the literature, and I think it's a smart choice, hitting that second receptor.
Agree.
So phenylephrine role is limited in refractory shock. Again, with pure alpha, you get that splanchnic vasoconstriction. You want to kill the gut. And it can actually lead to reduced cardiac function in rat models. They've done a couple studies of it, looking at it. But there's really no high quality data using phenylephrine versus any other pressor. And if you had, purely like a loss of sympathetic tone from like a neurogenic shock, phenylephrine might be the answer. But outside of that, there's just other pressors that are better supported by the literature. So I think we use norepinephrine. And actually, there was an interesting trial, or when I was doing this, it made me think of it. Did you hear they recently came out, the FDA came out saying that phenylephrine is like no better than placebo for nasal decongestion?
I didn't see it.
So it's like people have been using phenylephrine or, all the like Dayquil and all that. It's no better than placebo, which was interesting. But there was a shortage of norepinephrine in the U.S. Back in 2016, and so they did this trial where they looked at the most commonly administered alternative vasopressor was phenylephrine when they didn't have any norepinephrine, and patients admitted to the hospital during this time of shortage had a significantly higher inpatient mortality than when norepinephrine was available. So it's not saying that the phenylephrine caused them to die. It just said that when we had norepinephrine, mortality was lower than when we only had phenylephrine. Take those results for what you will, but a very interesting read was they not saying it's causation. It was just when we didn't have norepinephrine, more people were dying. Epinephrine, again, as I just said, should be thought of more as an inotrope than a vasopressor. It can raise those lactate levels. You can't use them to guide resuscitation. And as we just talked about, epi and norepi both act on alpha-1, so additional stimulation when norepinephrine has failed won't raise your MAP. And remember the ancillary effects of epi outside of the alpha-1 stimulation. You get that increased myocardial oxygen demand, increased contractility. If you're already stressing your heart, it's not going to help you out anymore. So epinephrine as a second line is probably not the answer. This is just something when I was putting these together and including the chemical models, I'm not super great with chemistry, but if you look at how closely all these molecules are to each other, epinephrine, norepinephrine, phenylephrine, I mean, it's almost the same molecular structure, just, very minor deviations. The addition of a hydrogen at the end of the chain or a hydrochloride at the end of the chain is the only difference. So I just thought it was interesting that all these molecules are very, very similar. And so it's no wonder that they act in similar ways. Just an interesting side point.
Yeah.
Dopamine, ample evidence that says epi and norepi are more effective in raising MAP than dopamine. They did a randomized study comparing dopamine and epinephrine in the treatment of shock. Great article in the New England Journal published in 2010. They did a subgroup analysis, 280 patients with cardiogenic shock, and they found that dopamine was significantly or statistically significantly associated with the increase in 2018 mortality compared to norepinephrine. So they found that people who got dopamine died a lot more frequently than those that got norepinephrine, and there wasn't a difference in secondary outcomes. So if we know that people are dying with dopamine and not necessarily with norepinephrine, then there's no reason for dopamine. So what's the future? Where are we headed? So that's kind of classic therapy, and where are we headed now?
Yeah, let me just pause you. So
sure.
to recap the management of vasoplegia, septic shock, some volume. That's kind of to be debated. Start with volume. Add a pressor.
Norepinephrine.
Especially if you start getting beyond 30 cc's per kilo.
Mm-hmm.
We're taking the stance that once you get to a certain dose, 0.1 or 0.2 marks per kilo per minute, you've already hit that receptor. So we choose another one, the V1 receptor with vasopressin, rather than sticking with the alpha, with the dopamine, with the phenylephrine, with the epinephrine. The only thing you didn't mention was steroids. I know I saw them earlier. Most clinicians will add hydrocortisone at that time. This is debated too, with the thought of maybe there's a component of renal insufficiency, so the cortisol is needed. And then we're essentially out of options. You know, you can keep flooding the alpha with more epi, more phenylephrine, more phenylephrine or dopamine, or you can think about going, which you're going to talk about, the other pathways, which
So
is,
yeah, I included steroids here at the end because it is debated kind of hotly.
yeah,
But I included steroids at the end. And I think that they do recommend them
yeah,
when your options are not working. So if you're going up on pressor, you've given fluid, then give the steroids. But it's actually when the fluids are working, or the low dose norepinephrine plus vasopressin is working, they don't recommend steroids. So I have that here in a little bit, but you're right. So a fluid challenge, liter or two, quickly, if that's not working, norepinephrine. And if you find yourself going up on the norepinephrine, 0.1, I mean really 0.2 for sure, you should be adding vasopressin. And then you have some other therapies if needed.
and then one brief thing, because before we get into this, because we do have other options, but the other part of the clinician needs to focus on why are they getting vasoplegia in the first place. If it's because of cabbage, you already knew that, but if we're talking sepsis, you need to work on antibiotics and source control and finding that, but
that's a great point. The broad spectrum antibiotics and source control should be, immediate, an immediate consideration, because the vasoplegia is not going to get better until you have source control, or at least, appropriate antibiotic therapy.
Yeah. So that's where we are as of October 2024. But these new therapies have been coming in. We've been, where I work at in the ICU several years now. So it's going to be interesting to see what you're finding here. So, all right, I'll yield back to you.
So the future, is uncertain, and there are some therapies out there, whether they work, whether they don't work, who knows? And it's hard to take patients who are this ill, put them in a randomized controlled trial, and determine, okay, this one therapy is what helped them. And we'll get into a little bit more, but I think it's important to remember the three classes of critical care patients in a trial. There's those that are likely to survive, those that are likely to die, and those where the intervention might actually work. It's hard to focus on just those people that it might actually work. And if we're talking about refractory vasoplegia, these people are already incredibly ill. So it's hard to design a trial where you just capture that subset of patients and then determine if this intervention, this one drug, is what made the difference or not. So the data is kind of mixed, but I think it's important to think about, these people are already likely to die. So if there's no mortality benefit necessarily, the end result of the trial, is it really because the drug didn't work, or is it because they were already likely to die? So I talk about that just a little bit. So the first thing is Vasopressin. Short-acting vasopressin, basically. It's a selective V1 agonist, improves MAP, improves cardiac index, blood lactate levels, decreases lung edema, extra lung water, and helps to balance fluids status, which I think is really important, especially in the beginning where we're flogging people with fluid. It was associated with higher survival rates compared to vasopressin and norepinephrine. So it's been studied pretty well. However, there's no strong outcome benefit yet. So there's several phase 2 trials that are occurring right now, And the preliminary results have found reduced excessive fluid balance, improves ventilator-free days, faster shock resolution, and patient survival within the first 7 days. However, it's really expensive, and there's not been a great RCT to say definitively this is a great drug. But there's several phase 2 trials, and in fact, one phase 3 trial looking at Vasopressin. So you could see this in the next couple of years as an option. Along with that, there's Vasopressin. It's a longer-acting vasopressin analog. And when compared to norepinephrine, it reduced catecholamine requirements and led to fewer rebound hypotension events. There's significant debate as to, should we continuously infuse this, or because it has such a long half-life, can we just intermittently bolus it? And what dose do we give? They have in animal models found that there's a negative effect on coagulation. It leads to procoagulation and can cause pulmonary vasoconstriction. So it's not super widely used, but there's a trial. It doesn't have a name. It's just this very long number comparing methylene blue and terlipressin for severe septic shock. So again, in the next couple of years, we should see some publishing on terlipressin to see if it's a worthy option. Something we might be a little more familiar with, and there are several centers around here using angiotensin 2, so produced in response to the renin-angiotensin-aldosterone system, and activates AT1 and AT2. AT1 results in vasoconstriction and releasing endogenous vasopressin. This trial, the AT2 for the treatment of vasodilatory shock, compared angiotensin 2 versus placebo in refractory shock. And they defined that as somebody already on high dose of norepinephrine. And they found that angiotensin 2 effectively increased blood pressure in patients with vasodilatory shock that did not respond to the norepinephrine alone versus placebo. So when you add angiotensin 2 to norepinephrine, you get a significantly increased MAP compared to placebo. It did not specify, though, whether they were able to come down on their norepinephrine dosages. They just used this to augment the norepinephrine. I have heard anecdotally, and I'd love to hear your opinion on it if you use it at all, though, that angiotensin 2 is pretty potent and people see some good results from it and are able to come down on the norepi. And when talking about a weaning strategy, they'll leave the angiotensin 2 on and try to come down on the epi or the norepi first. Do you have any experience with it?
Yeah, the truth is I don't know, right? As far as the weaning, I will say that for sure you're flooding with, you put them on norepi, they're on vaso, and you're looking for something, put this on, and you can certainly get to lower doses on norepi for sure. And it's an option, right? Because if your only option is going up on alpha, like at least it's another option. The downside, and I'm not sure if you'll get into it, is the side effects potentially of angiotensin 2. In particular, it can lead to bowel ischemia, but again, everything we're talking about, it's like kind of not really. You should still be focusing on the fundamental problem if you can get to that, whatever that is. But this is,
yeah, there's no silver bullet, and there's, it's life over limb or life over gut at that point. But it's something to consider when you're picking an agent. Is, if you're gonna save the person, or I should say decrease your norepinephrine dose just to kill the gut, then have you really, helped the patient out in the long run? Quick overview of AT2, how it works. So it's secreted from the liver, and then just a potent vasoconstriction, and then it increases salt retention via vasopressin stimulation. So it helps to keep some of that water in. So more water retention with a smaller blood vessel means increased MAP. Methylene blue is a nitric oxide scavenger. So it goes around and grabs up all those extra nitric oxide molecules. Remember that that's a potent vasodilator, and inhibits nitric oxide mediated vasodilation. It also inhibits nitric oxide synthase and guanylate cyclase. to work in tandem with vasopressors. So it prevents vasodilation, allowing the catecholamines to come in and clamp down, because otherwise you have the body, the cytokines, the nitric oxide is trying to make that vessel get big and big and big, and it's not allowing your pressors to clamp down. So methylene blue works to inhibit that nitric oxide so that the vasopressors can actually clamp the vessels down. Lay did a study noting that methylene blue causes a dose-dependent cardiac arrhythmia. The more you give, the more likely you are to have arrhythmia, coronary vasoconstriction, impaired gas exchange, and a decrease in cardiac output for doses greater than 2 milligrams per kilogram. So the recommendation is 1 milligram per kilogram. A lot of the data on this is observational or case reviews or animal models. But methylene blue is used frequently in cardiac surgery. However, it's increased or associated with increased mortality. And so this is what I was kind of talking about with the limitations of critically ill patients, is that if you're reaching for the methylene blue, they're already really, really sick. They're already on a bunch of vasopressor. And so, you know, it's associated with increased mortality, but were those people likely to die anyway? Mahaffey noted that mortality improved when given early rather than late. So what he took from that was that if you give the methylene blue early, you allow those pressors to clamp down, where if you give it too late, you're already off the precipice. It's already too late to give it, and it's not going to work. They did a human septic shock study. It's very small case reports, though, and they found that MAP and cardiac index were both increased when methylene blue was given in. And they found, though, that when too much methylene blue is given, just as Lay's studies found, that when you inhibit too much nitric oxide, you actually get a decrease in cardiac output. There's several additional trials that are ongoing right now. We'll see what they say. So far, the trial data has been mixed at best. Hydroxycobalamin, cyanokit, normally indicated for cyanide exposure, approved in 2006 by the FDA, with the incidental side effect of it increased BP. So the exact mechanism is unknown, but they think it's likely related to nitric oxide inhibition. And it modifies hydrogen sulfide emission and allows for increased elimination of hydrogen sulfide. Hydrogen sulfide found in the body is a potent vasodilator. So if we get rid of that, we get rid of some of that vasodilation. It causes that chromaturia. If you've seen that cyanokit urine, you know exactly what I'm talking about. But that cyanokit urine can actually interfere with renal replacement machines. And so it leads to increased clotting in people on renal replacement therapy. And because of the oxalate nephropathy, you get higher rates of renal failure, meaning you have to go on renal replacement therapy. But again, these people were so sick to begin with. Is it really the cyanokit doing it, or is it just their intrinsic illness? The data behind it is limited. Shah's group found that a majority of patients given hydroxycobalamin had an increase in MAP and refractory shock. And Barker's study compared hydroxycobalamin to methylene blue and found similar results, though they did have higher rates of renal failure in the cyanokit group. And it should be known when you give cyanokit that it's not an immediate effect. It can take up to an hour to see that increase in MAP. So you give it, it's got to scavenge all that nitric oxide if that's how it works. And so it's not going to be an immediate increase in MAP. It's going to take a little bit of time. Do you guys ever give cyanokit for refractory vasoplegia in your world?
So actually, yeah, most of this, I would say a lot of it's done in the, especially methylene blue, in the OR by anesthesia ahead of time. I would say more so than cyanokit, it's angiotensin 2.
Gotcha. And that seems the data seems to point to that as well.
You know, I was gonna, and we can talk about this later. If you're a flight nurse watching, or even a flight NP or a nurse practitioner, I think most of the evidence, the guidelines, if you're dealing with sepsis, it has your back on giving some volume, going norepi, going vasopressin, giving steroids. You start getting beyond that, you better rethink, number one, are you right? And I personally would have a discussion with, if I'm working the ICU and intensivist, I would just want to make sure, like, because I wouldn't just go starting these things willy-nilly, personally, because you better make sure you're right, because giving these things to somebody who's just volume down, or if you're wrong, like, it's going to make it worse. I think that's some like real world advice. Like, you start getting beyond the guidelines, you better have a discussion with an intensivist or some other people and kind of make sure everybody's on the same page with using these agents.
I would agree. And at certain institutions, there are only certain people that can order these medications because there are consequences down the road. And I agree with you. You better be right. And so, I think that when you follow the guidelines initially and you give some volume, you give some norepi, give some vaso, if that's not working, seek help, seek additional resources. Somebody else just to bounce ideas across. Because when you start reaching for these, untested case report supported, I mean,
Yeah.
it can lead to some bad things down the line. So, I would agree. It's good to reassess and maybe run it by somebody else if you're starting to reach for some of these things.
Yeah.
Corticosteroids, few trials have examined steroids in vasoplegic syndrome, but we have some data in sepsis. We know that they help restore vascular responsiveness by inhibiting COX-2 synthesis. You remember from the very beginning of the talk, COX-2 is a potent vasodilator, and nitric oxide synthase. But they're likely only needed or helpful if fluid and low-dose pressure is not working. And actually, Surviving Sepsis recommends in their recommendations, they say, we recommend against using hydrocortisone to treat septic shock if fluid and vasopressor therapy are working. So if fluid and vasopressor therapy are not working, they suggest the 200 per day, so 50 Q6 of hydrocortisone. And what were you saying?
How do they define vasopressive therapy? Is that one pressor, two pressors?
So it's great. It's interesting you say that. And if you look, it's a weak recommendation on a low quality of evidence. So, I mean, people point to surviving sepsis, and that's who you're going to have to answer to if you're ever taken to court. Is they're going to say, well, you have these guidelines. And you can say, well, it was a weak recommendation based on low quality of evidence. Doesn't matter. It's still the guidelines. I would say, and this is, and the people I've talked to, is that when you're escalating pressure, it's not working. So if you're escalating pressure, if you're reaching for the vasopressin, it's not working, give the steroid. I think what they're saying is if you give somebody who's just a liter down, you give them a liter and their blood pressure responds, they don't need steroid. But if you give them the fluid, you start norepinephrine and you're going up on the norepinephrine, give them the steroid. This study published in the New England Journal looked at hydrocortisone and septic shock, and they found a beneficial effect on 90-day mortality and shock reversal. And they define shock reversal as coming down off vasopressors. So they found that when you gave hydrocortisone and septic shock, you were able actually to come off or come down on your vasopressor. HAT therapy is kind of new. So they look, it's hydrocortisone, vitamin C, or ascorbic acid, that's where the A comes from, and thiamine, vitamin B1. And they found that exogenous administration of vitamin C potentiates the synthesis of vasopressors in the adrenal medulla, so increasing endogenous vasopressor release, catecholamine release. And critically ill patients are often deficient in both vitamin C and thiamine. And thiamine can help with microvascular function and integrity. So we want to kind of rebuild the microvascular space in the endothelium and prevent all that leakage of fluid and vasodilation, and thiamine can help with that. And they just did a pilot study that looked at this high-dose intravenous vitamin C, and this was in cardiac surgery patients, so it should be known. And they found reduced vasopressor requirements, but another RCT done found no reduction in time to resolution of vasoplegia. So this might work. It might not work.
Yeah. Can you back up a slide? So I didn't see your slides beforehand, so I didn't research this in the last, I don't know, 6 months or so. But I thought vitamin C and thiamine's been debunked as far as sepsis, but I don't know.
No, that's, and I believe it was the ascorbic trial.
Yeah.
Don't quote me on that, but I agree with you. It was like, oh wait, vitamin C is not worth it. So now it's this idea of HAT therapy, adding hydrocortisone, vitamin C, and thiamine all together. It's probably not anything, but it came up in my literature review, and maybe it's a way of reintroducing vitamin C and thiamine. But again, in
Yeah, I wouldn't
refractory
worry about it.
shock, is it really worthwhile?
Definitely in transport.
So yeah, this is just
Like,
this is like way down the line, and
just
so far
wondering.
the results are not promising, but it's out there, and so I figure that people have to know.
Yeah,
Um,
I'll have to look it up because,
yeah,
man, I
hat
feel like
therapy.
I feel like the literature and everything changes like every year or two. One minute they're saying we do it, and then like 4 years or 3 years later, we're not doing it. So I've learned to be very cautious with the newer trials. Like,
Oh yeah,
I'm more of a late. I'd like to see some serious evidence behind it. And even this whole 30 per kilo, like at one time that's recommended. At one time, the central line's recommended for every patient, you know, for sepsis. So I don't know. Some of these recommendations tend to change in a couple of years. So personally, and everybody can practice how they want. I'm more of a moderate to later. I buy in on things now, only because I've done so much and they later prove it. Hey, that doesn't work.
sometimes it's best to be conservative, and if you really want to talk about controversy, the whole surviving sepsis campaign started with Rivers' trial and Dr.
Yeah,
Rivers and his whole device and everything, and there was some shady stuff behind that, and so I agree. Sometimes it's better to be conservative, but this hat therapy's out there, and maybe
yeah.
they found individually the stuff doesn't work, but maybe if we combine it, it'll all work. So it's
That
out
said,
there. I don't know anybody personally that's doing it, but it is out there, and there are some trials looking at this hat therapy. So just if you see it, it is out there, but there's not strong evidence to support it.
yeah, that said, there's probably vitamin C and thiamine. I find that it's not probably not gonna hurt, right? So,
But
all right.
yeah, and maybe people are deficient in it. Does it actually make a difference? Who knows? But probably won't hurt you. So I just wouldn't be, I would never be reaching for hat therapy before I just tried a little low dose norepinephrine. So what are the dosing for these things? Methylene blue, 1 to 2 per kilo. Again, they found that with higher doses, you ran into some cardiac problems. So maybe start with 1 per kilo. Sanakit, 5 to 10 grams. It seems like 5 grams is given commonly. You can give another 5 grams, but 5 grams is the starting dose. Angiotensin 2 is an infusion, 5 to 40 nanograms per kilo per minute. And then the hydrocortisone per surviving sepsis guidelines is 50 Q6 for 200 a day. And I would say the steroid dosing is pretty standard across the board. So, like, how do we increase this stuff? In Busey's article, he gave a really good review of vasoplegia, and he uses norepinephrine equivalents, but he recommends norepinephrine. So, but he puts that in there in case there are partisans that want to use something other than norepinephrine. But he says norepinephrine, if it's greater than 0.2 per kilo, and you add in vasopressin, you need additional therapy. So that's what he considers refractory. So that's norepinephrine at 0.2 and vasopressin. If it's not working, you need to add something else. He starts with methylene blue, 1 to 2 per kilo. And then if it's not at MAP goal after that, addition of methylene blue, you either use angiotensin 2 as an infusion or you add in cyanokit. They recommend angiotensin 2 if you're at high risk for renal failure, people in refractory shock are, or use the cyanokit if they're at a higher risk of thrombosis. Neither, again, is really supported one way or the other, but this is his increasing algorithm. So start with, if you're on norepinephrine and vaso, then add methylene blue, and if that doesn't work, consider angiotensin 2 or cyanokit. Again, I think if you reach that methylene blue stage, you need to be talking to somebody else. You need to be talking to the intensivist. You need to, if you need to consult somebody, ask for help before you just start willy-nilly giving it. And then he provides this great little chart to just say, if your norepi's less than 0.5, your vaso's less than 0.07, you need to add any of this stuff. And he gives you this titration table. So say if we're going up, then we add our vasopressin. We can consider methylene blue and maybe start 10 of angiotensin 2 or administer cyanokit. And so he gives you this nice little table of kind of when to use what. And if you're still going up on your norepi, go up on your angiotensin 2. You should be given methylene blue following this little table. So this is just a nice little table telling you when to use what. What does this table actually mean? Likely that vasoplegic care will not move from high-dose norepinephrine plus or minus vaso to kind of a more multimodal strategy. So it's not just cranking your norepinephrine all the way up to 2 mics per kilo. We need to be using a more multimodal strategy with the goal of reducing our norepinephrine dosage. We need additional trial data, not only the ability to raise MAP, but also to improve mortality, decrease morbidity, and then cost effectiveness. A lot of these drugs are really, really expensive. So at the end of the day, like you said, fluid, norepi, vaso, and then when you want to reach for some of these other therapies, consulting, intensivist, adding, talking to a friend. And then if you're still going up on steroids, the data suggests that we should be, or still going up on pressor, the data suggests we should give steroids. And that's kind of it.
Yeah, good job. I forget if we really talked about this. And the other problem with giving too much volume is because they get all that volume in transport or at another ICU or whatnot. And they're an AKI, so their kidneys aren't putting it out. It's going somewhere, right? And it makes it a lot harder to extubate those patients in 3, 4, 5 days when their sepsis is better, they're off pressors, and now they're just intubated. Now you have that volume, working into their lungs, and so now it's a diuresis thing, and it takes them longer to come off the ventilator. It's wish I had the number. I mean, that's the hardest thing to answer is how much volume's too much.
How much volume? And there's so many factors that go into that, and there's probably no one right answer, but the data is out there to support a limited fluid resuscitation. We recommend limited fluid over, tons of fluid, but how much is right? And I don't know. And maybe it's better to give smaller increments of fluid, 500 a liter, wait, reassess, and then, before you're giving a ton of extra fluid. But I agree with you. It's hard when you have to fix the problem initially and then deal with the consequences on the back end. But a limited fluid strategy, and then early norepinephrine, and then if you're going up, add the vasopressin, add the steroids, and then consider some of these other therapies. And then antibiotics, like you said, antibiotics and source control is huge.
Yeah, I feel like that's probably missed. We get focused on treating the blood pressure when maybe the focus, yeah, you do treat it, but focus on what's making the blood pressure go down.
Exactly.
Whatever that is. And if it's an infection, well, antibiotics and source control, whatever's driving it. I think we're good. I'll stop it, huh?
Agreed. Thank you.